Hello, everybody. Welcome to the Foresight Centre seminar today on the future of long-term care and the financial side especially. So I'll make a short introduction in Estonian and then I'll switch back to English. I hope it's okay with you. So mul on hea meel teid näha siin täna Arenguseire Keskuse seminaril. Pikaajaline hooldus on meie selle aasta üks põhivaldkondadest. Natukene rohkem kui kuu aega tagasi oli seminar Eesti hetkeolukorrast ja täna siis räägime sellest, kust võiks pikaajalise hoolduse jaoks raha leida. Et kui Eesti avalik sektor kulutab võrdlemisi vähe pikaajalise hooldusele võrreldes teiste rikaste riikidega, 0,4% SKP-st, mis on üle 100 miljoni, siis võrreldav number rikaste riikidega, mis oleks enne keskmise lähedal, on 460 miljonit eurot aastas. Ja kui vaadata OECD stsenaariumeid aastaks 2070, 50 aasta pärast, siis on isegi võimalik, et vajadus pikaajalise hooldusele jõuab 900 miljoni euroni siis tänase SKP suhtes rääkides. Et tegemist on päris suurte summadega, olulise valdkonnaga ja siis Arenguseire Keskuses me püüamegi aidata neid teemasid läbi mõelda. See video jääb YouTube'is järelvaadatavaks. Me loodame ka, anname endast parima selleks, et jõuaksime ka eestikeelsed subtiitrid teha sellele seminarile. Ja kui te soovite küsimusi esitada, siis all on nupp Q&A. Ma julgustan teid esitama ka küsimusi eesti keeles, ma siis tõlgin neid panelistidele inglise keelde. Ja ma liigun tagasi inglise keele peale. So welcome everybody to the seminar at the Foresight Centre today. So long-term care is one of our focus areas this year. It's part of the government agreement, what they plan to do in the coming years. And we're hoping to contribute to understanding what kind of challenges we are facing in the future and what could be the solutions for these challenges. So the project is ongoing. And you would expect results in the fall, but we are arranging a series of seminars to raise the awareness on these issues and find common grounds to speak about these topics. So we had a seminar about a month ago on the current situation in Estonia. And if you want to watch it, it's available on YouTube. But today I'm really pleased to have a really wonderful international panel, a high-quality panel with us. We have Professor Tamara Konecka from the University of Chicago. She's a Lewis Block Professor of Public Health. She has written endless papers, I think like 100 or so, mostly on long-term care, the nursing homes, home and community-based care, all sorts of issues. It's impossible for me to summarize her work in this field. Then I have Anton Brown, who is a senior advisor and a research economist at the Federal Reserve Bank of Utah, and has recently worked on this topic, has several papers on these issues, and just 2 years ago published a paper on long-term care in Econometrica, which is one of the 3 leading journals in the field. And then I have Nigu Matanen, who's a professor of macroeconomics at the University of Helsinki, who's also worked on understanding the long-term care market. So when there's a lot of need for these services and there is need for financing, you can look for tax money, but you can also look for insurance market and private insurance markets. And US has a long history of trying out with the private markets. And there have been times when there are many insurance companies that provide these services. And I think currently there are not so many. And we're wondering what's the reason for this, right? If the government doesn't put a lot of money, but people feel that there is necessity for more services, why don't they buy these products from the private market? Is it that they don't care, or is there a market failure that we are facing that we could overcome and what could be the possible solutions for building a system where there's also private funds working in parallel. So this is part of the academic discussion. And then I've invited two people from the Estonian policymaker side, Kristina Kallas, who is the leader of Eesti 200, Eesti 200. And I've invited also Jürgen Ligi, who has not joined us yet. I hope to find him soon as well. But I think we can have the seminar even now. But I'm really pleased that Kristina today, you could join us today to give some Estonian perspective and ask questions on these issues. And we're planning to have the seminar in the more like a panel discussion style. So I'll give 8 to 10 minutes to all panelists, a bit less for the discussants, and then give floor back to comment each other, answer questions that have been raised. And then I start taking questions from the participants. So far, I don't see any questions yet, but we have quite many people listening us. So thank you so much, everybody, for joining us. I'm really excited and truly grateful for finding time for us today. So I would like to give first floor to Professor Tamara Konecka, and then to Anton Brown, and then to Nico Matanen. Please, Tamara, the floor is yours.
Great. Can you all see my screen?
Yes, we can see your screen. It's not full screen yet. We now see the presenter mode where we also see the slide coming ahead.
Mm-hmm.
So if you want to, there's the presenter mode. If you want to switch.
Mm-hmm.
I think when you show the presentation from the beginning and then
yeah,
up there should be a button for
maybe I'll just
okay, maybe
is this good enough? Can you see it? Not?
No, this is even smaller. So I think the full screen was actually good. The font on your slides is actually good. We can see pretty well.
Like this?
No, go to the full screen mode. I think this is the best that you had before from all the options.
Oh, I see.
It's always a tricky business.
Yeah, actually, I haven't had, after a year of Zoom, I haven't had this particular problem. So I'm not sure why we're having it.
There are endless different versions around, and this
right.
is the seminar setup. So all sorts of things happen that. Alternatively, I can also.
Do you want to bring it up?
I can also try mine, but if you try the full screen again, I think that was fine. At the bottom of the screen, if you press the full screen, that should.
Yeah, I thought that's what I was doing. I'm just trying everything. Why don't you bring yours up and then, you know.
Tamara, you could try stopping to share and try to reshare again. Good, looks good.
Okay, great. So what I want to do in my time today is to give a very broad overview of how we finance long-term care in the US. So everyone knows the demographics. I won't spend a lot of time on them. We know that the population is aging. The top line shows the age 65 plus population in the US, which is clearly increasing, and also increasing as a percent of the total population. What we're really concerned about is actually that bottom line, which is increasing at a greater rate, those 85 plus who are the prime users of long-term care services. And this is happening across the world. And in fact, I think a lot of Western Europe and Japan are about 20 years ahead of the US in population aging. So we're all facing the same problem, but there are a lot of countries in which it's actually worse than in the US already.
Tamara, it's not showing your current screen. I'm not sure why, but it's showing your your titles page.
Okay.
No,
That's it.
You saw that? Okay.
Yeah.
I don't know why that didn't switch. So anyway, this was the slide I was just talking about, but this, again, should probably be familiar to everybody. Did it switch now?
Yes.
Okay. So we spend a lot of money in the US on long-term care. Of course, it's questionable whether or not it's actually too much or not enough. We spent $379 billion on long-term care in 2018. This amounts to 8.7% of our total healthcare expenditures, which, our healthcare expenditures in the US in general are quite high. So this sounds like a lot of money, but, it may not be enough when we think about the risk and how many people are going to need long-term care as the population ages. So there are estimates showing that about a third to half of 65-year-olds today will use a nursing home at some point. And of those, about 10 or 20% will live there for more than 5 years. And this is a huge financial risk to individuals. And most families are unprepared for this expense, and it is indeed quite expensive. So this graph, it's a little bit old, but it shows that, this chart shows that in the US, a nursing home costs, estimates now are more like about $100,000 a year. It's a very expensive kind of service. Even if somebody is in assisted living, which is a lower level of care in the community, it's going to cost more than $40,000 a year. There's a large range in that as well. And, having a home health aide on average is about $20,000 a year. And when we look at what the income is of average seniors, most of those things are unaffordable in an absolute sense, let alone in an absolute sense, and also as a percent of people's income, of course. So individuals are generally unprepared for the high cost of long-term care in the US. So how do we finance this? I put system in quotes because I really don't think the US has a system at all for financing long-term care. It's never quite been a priority. So we have no universal payer for long-term care. There's no long-term care, there's no long-term care benefit on a national level. There's no sort of national long-term care insurance. We have a program called Medicare, which provides health insurance for almost all people over the age of 65 in the US and some other select groups. But that's really intended to cover acute care. In Medicare's charter, it specifically says, it's not meant for long-term care services. So it covers hospitalizations and outpatient care, but not long-term care. So people can go to a nursing home and get some rehab under Medicare, but the payment stops completely after 100 days. So what we have is no universal system of financing this care, but then we have a large safety net payer in the Medicaid system. So Medicaid was started to provide basically care for the poor. It was not really meant for long-term care, but it's become the long-term care payer of default. And so Medicaid ends up playing a large role in paying for long-term care services, both in nursing homes and in the community. But in order to qualify for Medicaid, individuals have to spend down their assets to almost zero, right? In many states, you can only keep about $2,000 worth of assets in order to qualify. And then once you basically exhaust your savings and qualify for Medicaid, the payment rates to providers are quite low. And so people who are dependent on Medicaid often end up going to the lowest quality providers who are willing to accept those low payment rates. So Medicaid is by far the largest payer in long-term care in the US. There's a very small private long-term care insurance market. I won't say much about that because I know one of our other panelists is going to talk about that a lot more. But there are a lot of supply and demand side reasons why the long-term care insurance market in the US has been quite small and never seems to have grown despite many public policy attempts to try to increase the size of that market. So the result is we have a very fragmented and incomplete system of financing care across payers and across settings of care. And this graph just shows that the role that Medicaid plays in long-term care. So Medicaid covers more than half of long-term care expenses in the US, again, as a sort of safety net program. But because long-term care is so expensive, a lot of people end up relying on this safety net. And in nursing homes, for example, about 2/3 of people in a typical nursing home at any given point in time are on Medicaid because, even if they started out as private pay, after a while, they can't afford it. So there is a lot of out-of-pocket spending, about 16%. There's some role for private insurance. And then there are, other state and local programs and the Veterans Administration, for example, that pays for some. But Medicaid is a dominant payer. And I should mention also that, in those figures I was talking about, formal care, just like everywhere else, there's still a large role for informal care, for family and friends taking care of people with long-term care needs. So what we see here is that the purple box is people who have functional impairment or cognitive impairment and need care. The purple box shows that those are the people getting only informal care, no formal care whatsoever. And that blue box above the purple one is people who are getting informal care and some kind of formal home care. These are all people living in the community, not in nursing homes. And so the vast majority of people are getting some informal care, and some portion of those are also getting some formal care, but informal care is still dominant in this country. So Medicaid, when it started, was restricted to paying for nursing home care for people who were eligible. And this was intentional because it's kind of a cost containment measure, right? They were afraid of people who, could rely on family or friends, instead getting this formal long-term care benefit, what we call the woodwork effect, people who wouldn't otherwise get services, using services because home-based care is so attractive. And so they restricted the benefit to just people who were eligible for nursing home care. Another way of saying that is they figured if you need nursing home care, you're sick enough to actually need the benefit. But that has really changed over the years. And so now what we see is more than half of spending by Medicaid on long-term care is in the home and community-based settings. This is intentional in part because home-based care is less expensive, right? Institutions are very expensive places. And so shifting people to the home setting where you can utilize informal caregivers and not pay for the housing portion of care does save these programs money. However, the cost effectiveness of that is really unclear because there are a lot of trade-offs. So people like to be at home, but certainly, especially when recipients are really sick, there's a much greater burden on informal caregivers. And we know that there are, costs associated with that, indirect costs, such as reduced labor force participation and healthcare costs for the caregivers themselves. The outcomes of this kind of care are also uncertain because family caregivers are often untrained. And we've done a series of papers looking at the outcomes of this kind of care and find that people getting home-based care are much more likely to be hospitalized in any given year than equivalent people getting more intensive care in a nursing home. So there are a lot of trade-offs to this kind of care that need to be considered, even though it generally is an attractive option. And then I couldn't nobody can really talk about long-term care these days without talking a little bit about COVID-19. I've been heavily immersed in the research on nursing homes and the effects of the COVID-19 pandemic over the past year. And, it was pretty much a disaster here and everywhere. And the only thing I'll say about this is that I think it really drew attention to the state of long-term care funding and delivery in the US. And I'm kind of thinking of this as a moment in time where perhaps we can think about some better alternatives to the way we currently finance and deliver long-term care. As some of you may be more familiar with these programs than I am, but there are a bunch of other models out there. So there are some countries in the OECD who have universal compulsory insurance programs of one type or another. There are also more hybrid models like France. The US and the UK and Italy are somewhat unique in having this, sort of no overall system, but a large safety net system. But in all of those cases, most of these countries have built on what they have in their acute care insurance, right? And I think part of the reason the US has not built a system of financing long-term care is that we've struggled so much over many decades. We've struggled so much over many decades to actually insure our population for acute care across the age spectrum. And so, usually countries kind of build their long-term care insurance on top of these acute care systems. So I'm hopeful now as the Affordable Care Act and Obamacare get kind of settled in this country, that coupled with the crisis created by the pandemic, that this is a good moment in time to think about how to better finance long-term care in the US. And specifically, I think, the way to go would be to have a new kind of federal benefit that ensures better access and reduces some of the fragmentation we have now. So I will end there. Thank you.
Thank you so much. It's in a way good to hear that also US doesn't have a system, or a system in quotation mark. I think that these challenges are pretty much the same in many places, and it's a complicated field. So it's also not clear that there is one best system. There are always pros and cons and winners and losers, whatever the system is. So that's why we're thinking also what the future could be. So now I'd like to give floor to Anthony Brown. Please, floor is yours. Floor is yours.
Look okay?
Looks good.
Okay. Well, thanks so much for inviting me. And I'm Professor Konecka has saved me a lot of time because she's provided a lot of background about US long-term care arrangements. I'm going to focus a little bit more on the insurance aspect. As Professor Konecka pointed out, nursing home risk is significant. As many as 50% of 50-year-olds and older will experience a nursing home stay before they expire, and costly. According to the estimates in one of our projects, conditional on having a long-term stay of more than 100 days, the median stay in a nursing home is about 3 years, and at $100,000 a year, you're talking about a lot of cash as compared to the resources of many retirees. On top of that, as Professor Konecka pointed out, many who never enter a nursing home will require long-term care assistance of one form or another. Due to the aging, longer life expectancies, and in the United States, aging of the baby boomers, we anticipate demand for long-term care services to increase in future years. In terms of the demographic, a little bit more demographic information about who needs assistance, well, women are very important in two respects. First, they are the primary providers of informal care, yet they also have longer life expectancy, and dementia risk increases with age, and so as many as 70% of people requiring long-term care are females in the United States. There's been some different types of research talking about this, but what are the sources of dementia, and how is it changing over time? And there's some evidence. First, dementia risk is more concentrated among women. It's also more concentrated among minorities in the United States. And it seems to be more concentrated in routine jobs, and it's negatively related to educational attainment. But the prevalence, according to a recent paper by Hudomit et al., is only declining very slightly over time. And so it's at this point, there may be some innovations, but it's hard to anticipate significant declines in the prevalence of dementia moving forward, which suggests that these aging considerations are going to be very important. How do individuals insure against this risk? Well, traditionally, the thing they've done is they've invested time and or money in their children and community, in church and friends. And what's happened is the primary providers of care in old age to people who require assistance have been children and the community. The other way that they've done it, and this has been something that has been very important in recent years, because as people have acquired more wealth, as societies have developed, it's become easier for them to self-insure and accumulate. They can accumulate and retain real and financial wealth until late in life. But there's an issue with that is you may not have, say, a nursing home event, and then you have all this wealth that you may leave in the form of an accidental bequest. It gets tied up, for instance, in equity in the home, which may or may not be a good thing, depending on how you care about your kids and bequest taxes in your particular country. In the United States, we have the following schemes that are used to reduce the need to retain large amounts of wealth until late in life to provision for nursing home risk. One is long-term care insurance, private long-term care insurance. And the nature of that contract is you pay a premium, and the typical age when you might buy that insurance product in the United States is around 55 to 57 years of age. And then it pays out on average somewhere between 15 and 20 years later. But you pay the premium, and one of the things we've seen, I'll talk about a little bit more in a few minutes, is that these premia you pay for 10 years, and suddenly you get a letter from your insurer saying, "Oh, we're going to increase the premium next year by 150%." So the alternative, one financial alternative to that, is something that's referred to as a deferred annuity. A deferred annuity you can purchase actually until relatively late in life, and you could say buy it at 65 and start receiving payments at say 75. And the term leverage is used to refer to the fact that some of these deferred annuities, if you have a nursing home event or a long-term care event, that the monthly payment will double or triple. So you get 200% of leverage or 300% of leverage. One paper that talks about this, one recent paper, is a paper by Koijin et al. In the Journal of Finance. Professor Yogo at Princeton has done a lot of work on deferred annuities. The third possibility is something that seems to be growing a lot in our country, And the basic idea is that you buy a home or a condominium in an assisted living community, and they commit to providing assisted living if you need it, and even nursing home services if you need it, in exchange for the property at the time of your death. And these can be much more complicated as I've described it, but that's kind of the simple arrangement. And then the third one is to rely on public assistance. In the United States, that's been Medicaid, as Professor Konetsky explained, means tested Medicaid benefits. So I want to try to explain how the picture looked traditionally. This is not actual data, but it's just meant to give you an idea about what traditional arrangements look like. And traditionally, government only played a tiny role for those who experienced long-term care events. Most of it was provided by family, community, and church. And people who were affluent enough, they could afford to buy services, long-term care services. But traditionally, this has been provided informally by the community, and many laws to this date place the brunt of this on either the community and or the family. Okay. Now, this is how the picture has changed in many countries, and there's lots of cross-country variation in the right panel that I'm showing you here. I want to talk a little bit. I spent a good part of my career working in Japan at the University of Tokyo. And in Japan, what's interesting is first, the government has gotten much more involved in providing public assistance for long-term care risks. And there's a sense in which they were kind of dragged into this arrangement. In Japan, the traditional arrangement was that the eldest son would marry, move in with the parents, and you'd have a multiple generation household. And the daughter-in-law would provide long-term care for the parents-in-law, okay? Now that arrangement looked pretty good when life expectancy of the mother-in-law, for instance, was 54, which is what it was in 1947. But by 1985, it had risen to 80, the life expectancy of females. And that social contract doesn't look as good to a daughter-in-law if her mother's going to pass away in, say, 10 years or 15 years. Well, it's very different if she's going to be with her for 40 years. And what Japan saw was that many old people, they saw two different things. First, households with multiple generations, the fraction of those has declined by 50% since 1960 in Japan. The other thing that happened is that hospitals were finding that there were many retirees that had moved in permanently. And so they basically taken up residence in hospitals. And so they started the public insurance, long-term care public insurance program. They called it preventative. And by what did they mean by preventative? We want to keep old people who are sick out of hospitals. And a big focus of that program has been to come up with arrangements where services are provided in the home or in the community so that they can stay in their home longer. Now, obviously, there's huge differences. I'll talk a little bit more about this in just a few seconds, but let me move on. The US private long-term care insurance market is surprisingly small. And why is it surprising? Well, demand, as we've seen, demand for long-term care insurance should be large and growing. That this is a big risk, and it's an expensive risk, and you're likely to experience this type of event. And the fraction of retirees of the 65 plus population is growing in the United States and many countries. In spite of this, so you'd think that the insurers would be jumping at this market. This looks like a growing market and potentially very lucrative. Unfortunately, long-term care insurance take-up rates are very low. Only 10% of Americans aged 65 and over own a private policy. Coverage denials are very common. If you look in industry data, there are estimates around 20%. In a paper that I'm going to talk to you about in a few seconds, we estimate that denials could be as high as 38%. Coverage provided on being offered insurance, not being denied coverage when you apply, coverage is incomplete. It provides payments, typically cash payments. It does not guarantee a service. Moreover, the loads are high. And by loads, what I'm referring to is the markup over actually fair insurance. The markups in the United States are as high as 51 cents above actually fair pricing. So if actually fair was $1, was $1, then you're paying $1.50 per unit of coverage. In spite of it being expensive to the consumer, insurers are finding the profits are low, and many insurers have exited the business. And those who are still in the business treat this product as kind of a toxic asset class for them. General Electric is one recent example. Okay. In this project that I'm going to talk to you about, I and my co-authors, Karen Kopecki and Tatiana Kroshkova, we analyzed the role of 3 different factors in the private market for long-term care insurance. The first is adverse selection. Adverse selection is simply that if individuals know that they have high risk of a nursing home stay down the road, they're more likely to purchase long-term care insurance. And that kind of makes the pool more expensive, the price goes up, and you can have actually a pool enter into a death spiral. Okay, so that's one factor is private information, that as the price goes up, only the people who have most information that they're high at risk will purchase it. The second thing is long-term care insurance, as compared to other types of insurance like life insurance or casualty insurance, they're more expensive to administer. The underwriting is more complicated. There's lots of testing done up front and underwriting, and paying claims is an ongoing monitoring process, requires ongoing monitoring as well to ensure that the person still is ill enough to qualify for claims payments. The third one is public insurance. The key thing I want to emphasize about Medicaid that Professor Konecka didn't talk about is that Medicaid is a secondary payer. If you own private insurance, that pays first, and Medicaid benefits only come in after those benefits have been exhausted. And that it's also asset tested, and so your assets on average have to be around $2,000 or less. So in practice, apart from the very poor in terms of wealth, the bulk of Americans are paying for long-term care insurance themselves. What do we find? Well, we find that all 3 of these factors that we model matter, but the importance of them vary depending on wealth of the individual. For wealthy individuals, adverse selection and administrative costs are most important. If you're wealthy and the product is expensive, then you're likely to self-insure instead and not purchase the product. For the middle class, all 3 factors matter. The option of maybe benefiting from Medicaid down the road, which is free if you don't have private long-term care insurance, but administrative costs and adverse selection are also important for them. For the poor, there's no point to buy private insurance because they're paying something for something that they'll get for free, okay, through Medicaid, and because Medicaid is a secondary payer. The other thing that we find is that most individuals actually prefer partial coverage, even if it's not actually fair, so in the sense that it's expensive relatively to the actually fair cost, as compared to a full insurance of actually fair, full coverage actually fair product. So they actually prefer partial coverage given the availability of public insurance and savings for other reasons. So let me finish by just talking about potential roles for the government in the long-term care insurance market. Government subsidies or mandates to purchase private long-term care insurance are likely to increase take-up rates of private insurance. We have tried some government subsidies, but the devil is in the details. The way these programs have been set up in the United States haven't led to a big uptake. Mandates may be a better measure, or kind of thinking more about the details of what the conditions are under which you earn a subsidy. We could talk more about that later. The other issue is this is a unique product. You, in principle, you want insurance down the road, and you're starting to transfer resources to your counterparty now, be that the government or a private insurer. And there's a question: will my counterparty pay me back down the road when I need the benefit? And that can apply to the government as well as to private providers. For private providers, it's important that you have regulatory oversight to ensure the private long-term care insurers have the resources and service providers provide the service that people are asking for 20 years down the road. There's an important question: who bears the aggregate risk, the individual or the long-term care insurer? And this is something that we've had to deal with in the United States. In many cases, it's been passed on to the individual. Means tested, we have found in other research that means tested public long-term care insurance is valued even by relatively rich individuals because they face some risk of ending up old, poor, and alone, even relatively affluent people. So means testing is an attractive arrangement according to our analysis of the United States. Universal public long-term care insurance, it's easy to build political support behind because everybody qualifies for benefits down the road, but it's a lot more expensive. Japan is discovering this, and Netherlands, which allocates about 4% of GDP to long-term care, have discovered this. And both countries are thinking about ways to scale back their programs. Finally, there's some recent research by Barczyk and Kradler that has suggested that small subsidies to family members under policies that encourage home ownership and bequests may be effective in inducing family members to provide informal long-term care services. Thank you.
Thank you so much. See how complicated this arrangement is and how many factors one needs to take into account when planning the years that you might or might not need to spend a lot of money. I would like to give now floor to Professor Nico Mätänen from the University of Helsinki. Please, floor is yours.
Thank you, Lenno. Good afternoon, everyone. It's an honor to present in front of members of the Estonian Parliament. So I try to say something about how to combine the private and public financing of long-term care. Now, my starting point here is the current situation in Finland, which I think is definitely quite different from the situation in the US. It's probably also quite different from the situation or the current situation in Estonia. But I still think that some of these considerations should be, to some extent at least, should be relevant also in your country. So first, a few points about the background and the current situation. Well, actually, I think the first 2 points were already made by the previous speakers. So, but they are very relevant. So let me repeat them. So first, long-term care needs vary a lot across individuals. So some people never need it over their lifetime, and some people need it for several years. And then at least sort of an institutional or formal long-term care is very costly. And it's probably always going to be very costly, basically because it's so it's sort of a labor intensive. So we cannot, I guess, fortunately, we cannot replace nurses with cheap machines or robots. So it's always going to be costly. So here in Finland, people rely on either informal long-term care, which of course is not always available, or tax-financed formal long-term care that is currently administered and also in many cases also produced by municipalities. So this formal long-term care, so typically in a nursing home, is heavily means tested here. So the user fees are typically up to 85% of net income. So I should perhaps specify here that it's tested against after-tax income, not wealth. So you're not supposed to run down your assets, but again, they sort of confiscate a large part of your net tax income in case you need formal long-term care. Still, given that long-term care is so expensive, and given that old people typically don't earn that much, most individuals who need this type of long-term care, they only, their user fees only cover a very small fraction of the total cost. So this is, this is public insurance for, for most, for a huge majority of Finnish citizens. However, the sort of given that it's administered by municipalities who are relatively, and the municipalities are relatively autonomous in Finland, the eligibility criteria and also the services differ across municipalities quite a lot. So currently, very few people use private savings to finance long-term care in Finland. And private insurance products are, I would say, totally unheard of here in Finland. So the market for private insurance for LTC simply doesn't exist in Finland. Now, I think, and I'm not the only one, that there is a case for increase in private financing of long-term care, also in Finland, even though we think of ourselves as, even though we think of Finland as a welfare state, which always takes care of its citizens. So one reason for why I think that there's a case for private financing of long-term care also in Finland is simply that there is increase in demand for long-term care services or for better services. One reason for this is the population aging, and the other one is simply that as people become richer, they also want higher or better services related to long-term care. The public resources, on the other hand, are limited, and the level of taxation is already quite high here. And another issue is that people have obviously different preferences. So some people would be willing to pay a lot more to get better long-term care services than others. And it's also, I think, a lot about freedom of choice. So people would like to be able to choose, whichever service provider they want. Whereas currently they are very much restricted by what the municipality is offering to them. And more generally, I would at least say that the society should arguably guarantee a minimum level of long-term care for everyone, rather than sort of services that satisfy nearly everyone in society. So all these points, I think, speak for all these, I think, arguments for increasing the role of private financing of long-term care in Finland. So how to make it easier to use private savings to finance long-term care then? Well, I also think that, ideally at least we would have a market for long-term care insurance. And the main reason for this is that ordinary saving is in some sense a very inefficient way to finance long-term care. You need to save a lot to make sure that you have enough resources in case you happen to need long-term care for several years. But on the other hand, then there's, again, as was already explained, there's then a high risk that you will never you will just end up leaving a big accidental bequest, because you will not need, many people will not need long-term care. So it would definitely be better to pool risk via some type of an insurance arrangement. And that would reduce drastically the amount of savings that is required to prepare for long-term care risk. The other issue, which I think is also crucial, is that it should be possible to somehow to sort of complement or top up, the social security or the current tax-financed public insurance. So one issue here is that even if we had sort of competitively priced long-term care insurance products, the price of the insurance would still be so high that the poor Finnish citizens would very few of them would be, could afford to finance full long-term care insurance on their own. So that would just be relevant for a tiny fraction of the very, very wealthiest Finns. On the other hand, there also is little incentive to buy private insurance if it means that then you give up the tax finance public insurance altogether. Right? I mean, it's conceivable. We can think of a system where some people, presumably the very wealthiest, they sort of finance their long-term care insurance all on their own, and they then just forego, the tax financed long-term care insurance that is typically provided by municipalities. So for some people that would be okay, but for a huge majority that would not make much sense, because these same people are paying for the system. So that would be one argument why I think it would be crucial to think about carefully how to complement the private insurance or whatever type of private financing of long-term care with the public insurance. How to then sort of improve the situation in practice? Well, here in Finland, I think it would be important first to sort of clarify and harmonize the eligibility criteria for the tax finance long-term care that we currently have. As I mentioned, these criteria vary across municipalities, at least to some extent. So I think, if we could harmonize those criteria across municipalities in Finland, well, first that would make it easier for people to sort of prepare for that risk, understand what they are getting from the society, what is the sort of welfare promise that is given somehow implicitly by the society. And these eligibility criteria could perhaps also be used as a benefit trigger in private insurance policies. So I think they might be useful also when thinking about private insurance contracts. So the insurance payments could be made perhaps conditional on the eligibility criteria that are used in the public sector. And the other way, another step or reform to make it easier to use the private financing, I think, would be to introduce some type of vouchers, so that instead of going to the nursing home that the municipality assigns to, where your municipality assigns you could choose to take a voucher. So that would be a euro-valued voucher, which you could then use to buy, together with your insurance payments or your own savings, you could then use to buy long-term care services from whichever service provider you wish, right? And importantly, since the tax finance long-term care is means tested, in the sense that the user fees increase with net income, I think it would be totally logical to make these vouchers sort of means tested as well. So that would mean that low earners would be eligible for larger vouchers than high earners. That would also sort of ensure that this type of reforms would not or should not sort of dramatically should not have very large sort of a distributive effects, which I think most people Finland would probably dislike. Thank you.
Thank you so much. I think it's wonderful to see how different the means tested could be in different countries, what it means, how you can define it very differently, and what are potential solutions. So I'm really glad that Jörgen Ligi could join us. He has been with us already for some time. But first, I would like to give floor to Kristina Kallas for comments and questions, and then to Jörgen Ligi, and then everybody can have a chance for general comments.
Yes, thank you very much for the presentations. I was listening very carefully. I'm not really a person who knows much about long-term care, I have to admit. I'm a political scientist, and I'm not in politics for too long, just about 2 years, and not even in parliament. But thank you for the honor of being in this team now to listen to you. I have one kind of a rhetorical question from the political point of view, and then some two specific questions, if I may put them on the table. The rhetorical question actually came after listening for Professor Konecka's presentation, because, and I think Professor Matonen and Anton Brown later also referred to this, the situation where we are today is basically that our expectations, because our living standards have increased significantly. The generations today who are becoming older and living longer have been living in a very good and peaceful and economically very good environment. So the expectations for elderly life are quite high compared to the previous generations. So the expectations with each following generation, assuming that there are no cataclysms happening, are probably going to be raising. So each next generation is going to be expecting also a better care once they will need it. So there is this kind of a spiral development of expectations regarding the standards of care once we need the care. And but at the same time, we know that we can't afford this constant increase of the care, at least not based on the current resources that we are putting in. So the politician would ask, what should we do? So what kind of decision should we make? And this is more maybe a rhetorical question, but maybe you want to discuss with us is, should we manage the expectations? So should we actually start saying to people that don't expect this to happen to you once you become older, that everything will be taken care of? Or should we start looking for resources in order to be actually capable of affording this kind of a higher standard care? So these are usual questions. So which way should we go? Sometimes I have heard also in Estonia in discussions that we should actually maybe manage the expectations. Maybe we should say also for the pensions that don't expect us to be paying up you once you're retired a good pension, because we can't just simply afford it. That's it. So this is a managing of expectations. A more practical question, Anton Brown, in your presentation, you brought out 3 ways how people can either themselves take care or what kind of strategies they are employing in order to ensure the standard once they are not capable of taking care of themselves. One is to invest in children, in church and in community. I think this is going down in a way that people are making much less investment there than they used to do in the past. The second is to invest financially into some kind of insurance system, which is going up, but not the way we would have thought it is. And I think in your presentation, you actually brought out the numbers very clearly that this is not going up in a high numbers. And the last one is relying on a public assistance, meaning the state or some kind of a state support, which is increasing. And as a politician, I could feel that there is an expectation that the state or the society will take care of me from my taxes that I pay nowadays. So this is really going up, these expectations. So my question is, what is the foresight? Has there been any foresight research? What do the experts say? What should we actually do? Should we start pushing the society towards self-insurance more, and also maybe pulling them back into investing more into children, communities and churches and guaranteeing some kind of a support from there? Or we should continue raising the expectation that there is a public assistance that is possible to give them. So what kind of expert advice would be there? Or maybe it's a combination of all 3, but then how to combine those 3? And also from Professor Matonen, I understood that Finland is moving, not moving, but I think maybe your recommendation, if I understood you correctly, please correct me, from this minimum public care that they might have now, and which is guaranteed, I understand, but there are people who would be willing to have more than minimum, and that there is a need in a private sector to provide this extra for those people who are willing to pay more or willing to put money more, but the private sector is not yet developed in Finland in that extent that this would be an offer. So what is the reasons why the private offer is still not there if the demand is there? So that's my question. Thank you.
Thank you so much. And before you start answering, I think it's better if I give floor Jürgen Ligi, who is a member of parliament, previously has been Minister of Finance and held different positions in the government. So please, Jürgen, if you're here, yes, the floor is yours.
Thank you. I'm not sure about these arrangements, but I thought you were expecting me to comment on the political context a little bit. Am I right?
Yes, absolutely.
Okay. First, just a second. I would say that this LTC, the political context for public insurance is very bad at the moment. Some of us know already, but Estonia is abolishing compulsory second pillar pension. So, and during this process, the whole idea of saving and insuring has been heavily compromised. So it's very hard to discuss it rationally at all. But the latest news is that the ministries are at the moment bringing this back to the political agenda and starting to discuss it again. I mean, this public insurance. The other bad context is long-term fight against labor taxes, and effectively those insurances tend to be like act like labor taxes. We have, of course, pension insurance already. We have unemployment insurance. We have got also healthcare insurance, and we can't talk much about industrial insurances, if this is the right term, and disability insurance, which also have been long-term proposals for politicians, but haven't been introduced. The second, and then of course this long-term care insurance, so I can't promise it's discussed in the near future. In general, I can say that Estonians, like maybe many other nations, but not all, are, it seems to me, have used to be cured at home and informally, rather than in nursing houses. It's very different from at least Sweden, I think. And the formal system is very expensive for clients. The burden lies very much on the clients, and but we can't say it's not developing. The demand is there, and then the system slowly develops. And then there have been also public investments in this. There is not much talk about private insurance. As in America, the market is, to me, I think, very small, and people are not thinking that long ahead. What else? I think this is mainly the points I wanted to make. Thank you.
Thank you so much. I think it's really important to understand where we are and where we could go and what we want. So I'd like to give floor now back to the academic presenters in the same order as before to answer the questions, comments, and maybe you have reactions to each other's presentations as well. Tamara, please.
Great, thank you. I wanted to start by responding a bit to Christina's rhetorical question about managing expectations. So it's a really interesting one. I think that, long-term care services and quality of life in older ages, in economic terms, it's a normal good, right? So as our countries become wealthier and as we have more resources to for a variety of things. It's quite normal that we expect better and more services in old age, right? This is true of healthcare in general. And there are a lot of arguments about, how much is the right level of spending on healthcare in general, right? But I think it's a normal good. So as countries have more income, we're going to spend more on healthcare, and that includes long-term care. So I don't know that managing expectations is a real option, right? I think people will want more of that. And then it reverts to the sort of the political process of what are, where does that priority stand, improving long-term care versus improving education and all the other kind of things we want to spend money on, right? So it's really a matter of choosing among alternatives. I don't think that lowering expectations or preventing them from increasing is realistic. I would also say on that point that not thinking more about spending more on long-term care or reforming the system, is a choice in itself. And in a sense, lowering expectations or not providing services, to me, just has huge implications, certainly in the US, for equity, right? Because lowering expectations generally means that the well-off will still be able to afford better and more long-term care and enjoy a higher quality of life in older ages. And the burden will fall to either the poor who are receiving, safety net services, or the middle class who in the US pay, what is the equivalent of this huge tax of getting rid of all of their assets in order to qualify for Medicaid. And so, I think that one has to also consider the implications of not spending more on long-term care, and especially, I think, the implications for equity. The other thing I wanted to quickly comment on is this idea of a public-private partnership, which to me is, a lot of people touched on that so far, but to me is the only realistic solution. As we've seen in the US, the private long-term care insurance market, for all the reasons that have been mentioned, has remained quite small. I think that, after multiple attempts to expand it, we should kind of give up on the idea that that's going to cover a large portion of the nation's elderly. And at the same time, a completely public system, as we've seen in countries that have tried to do it, is really expensive and, perhaps unreasonably so, given alternative uses for that money. We saw under the Affordable Care Act, Obamacare, that was passed more than 10 years ago now in the US, there was an attempt. There was part of what was in that law was something called the Class Act, where it was basically a national long-term care insurance. And one of the stipulations that Congress included was that it be completely privately funded. It was going to be federally administered, but completely privately funded out at least 70 years. And after several years of trying to make the numbers work and come up with a premium that people would be willing to buy into, because it was not mandatory, they had to give up and repeal that part of the law. And I think, that says to me that the only way to go is a kind of public-private partnership, hopefully one that would be means tested so that it would still provide access to lower income individuals, but without the huge discontinuity that we now have in this safety net system, where people have to get rid of everything in order to qualify for Medicaid. So I'll stop there and let my co-panelists weigh in.
Thank you so much. Tony.
Yes. Let me first chime in on Ms. Callis's questions. The rhetorical question is, it's not necessarily the old people want more nursing home services. What they want is a high quality of life. And in many cases, a high quality of life for them is just social interaction with other people. So things like a community center where they can go and talk to other people on their own age may be cheaper in a whole range of ways, because the social interaction slows onset of dementia and thus keeps people out of nursing homes. The tough problem for informal care or for any society is, how do you deal with a person who goes for a walk and 5 minutes later doesn't know how to find their way home? There's a certain amount of intense care needed, because dementia, you've lost your way, but you can't cognitively find your way or come up with answers on how to get home. And that creates panic in your own mind, fear and panic in your own mind. And unfortunately, these types of issues often require intense care, a level of care that's quite intense, and that family members may not be willing to provide. And so when we ask who, well, it may not be for the person that we're doing this. We may be doing it because the kids don't want to deal with this. They'd rather have the person in the nursing home. When the long-term care, the private market started in the United States, the insurers thought, oh, this is a great product because nobody wants to go to a nursing home. And so we don't have to worry about adverse selection or moral hazard. But they discovered that actually in many cases, it's the family that wants the person in the nursing home. And so there's an important question about who. Should public benefits grow? Well, we've seen in a number of societies. I gave the example of Japan. Japan created its public long-term care insurance because public expenses on hospitals, there's public coverage for hospital stays, and there are out of pockets, 10 to 20% depending on your age for retirees. But that expense was very high, and the government said, well, let's invest more resources in trying to keep people home. And the Netherlands is moving in the same direction. They're trying to keep people home longer by providing more services in the community. I believe from what I've read about Estonia, that's an important part of the current solution in Estonia, is having care managers that help people find the appropriate level of care within their community. But then the demand, as society ages, the demand for those types of people increases. And Japan has a shortage of those people now. I want to mention, I want to pick up on what are the most promising options or changes. There's not going to be a single answer. I tried to give a variety of different solutions. I think there's going to have to be some means testing. For the reasons that Professor Konecka emphasized, we don't want old, poor, sick people on the streets asking for handouts. No society wants that. And so there's going to be some type of safety net. And I think societies that try to do universal are finding that doesn't work. Mandates of a private purchase of maybe even a small product might be good, that would increase take-ups. Germany has something along those lines for people that are self-employed. They've got to buy a product, but they can choose what they buy. And there's some specifications that describe what they buy, but it doesn't have to be a particularly rich product. The final thing I just want to mention about policy, there's an increasing amount of attention on old people by scam artists. And part of that is that if you're old and retired and you've outlived your life expectancy, how can you adjust your income flow? The only way you can adjust it is to increase your cash flow from your savings. And that creates an inducement to look for more attractive, a susceptibility to people to look for more attractive investment opportunities. I can tell you my parents are getting several calls a week from people that are trying to offer them those types of opportunities. And the financial services industry is well aware of this, that they're seeing clients, they're old and experiencing sudden declines in their financial wealth. after having spent a lifetime of saving. Thanks.
Thanks so much. Nico.
Yeah, thanks. Let me also try to comment Christina's question or comment on managing expectations, because I think that's a very important issue, and I think that also relates to what Jürgen was saying. So first, I totally agree with with Tamara that in some sense it's totally natural that as we get richer, we also want to have more or better long-term care services. And there's nothing wrong with that. And in some sense, I think a successful society should try to make that possible, right? But the tricky thing here is the tricky thing here is the connection with the public sector or the tax system, right? And the reason is that as we get richer, or with economic growth, I mean, we can afford, economic growth makes it easier to afford many things. I mean, poor people have mobile phones that are very high quality now and that they could only dream of 20 years ago. But that's not the case really with long-term care services. And again, the reason is simply that it's so labor intensive. So this type of services with economic growth, they also become more expensive. And I think that's important. And then we just have to think about in a sense the size of the public sector. I mean, how high tax rates we will sort of accept or tolerate. So I mean, these discussions go hand in hand in a sense. And it's for that reason, I think that indeed, in some sense, I don't know if it's about managing expectation, but definitely I think a sort of an honest and open discussion about the future of long-term care is, it would be very important, so that, people know what to expect in a sense. I mean, there are endless ways of alternative uses for the limited tax revenues that we have. So therefore, I think this really is a crucial issue. And I would say that in Finland, I mean, the sort of the implicit welfare promise that the society gives to citizens is that, and it definitely should be made clear. It's not totally clear to me, for instance, what to expect from the system in a sense, because there are inherent pressures there related to the financing of the public sector. So yes, it's a debate that has to be should be that we should have already in order to make it easier for people to plan for their own future. And also, I would say, one reason why I think it would be good to make it easier to use public financing to finance a small part of the long-term care insurance is somehow to try to sort of alleviate this pressure that I was just trying to describe here. So that those who really want to have a much better services, they shouldn't perhaps expect that it will be tax financed, but we should make it as easy as possible for themselves, to finance at least part of that. Right. Thank you.
Thank you so much. I think this point needs to be stressed more, that we can't just expect the private insurance to pop up when there is need. First, the market needs support, and the public system needs to be designed so that there is space for the private system. If you really do a replacement, if you take the public money away completely from those who have a private insurance, then people don't have incentives to go for the private insurance, and the market collapses. So that when designing the system, one really needs to pay attention to these incentive schemes that are created. Christina, Jürgen, do you want to comment on the reactions?
Yeah, no, of course, I wanted to just ask it rhetorically, because and not really think that we should lower the expectations of people. I mean, none of the politicians would ever dare to do that. But I agree with Professor Määtänen that it's not entirely clear what I personally can expect from the state today. And maybe my expectations are way beyond what actually the state can afford, and even if they increase taxes, even in that case, they might be able to afford much less than I expect today. So there is some kind of a, I would dare to say, public over expectation regarding the services, and not only at the end of the life, I mean, in many other aspects as well. So this too high expectations, if I may so, I don't know, but, or maybe unrealistic expectations is maybe better, need to be managed better. I feel that personally, at least. That, having said that, I of course think that the ultimate goal should be to have as high living standard and comfortable life as possible. And that should be the task and the goal of everybody, obviously. But just not to make this gap between what really can be afforded and what people think that can be afforded. So there's this gap. I actually forgot to ask a question from Anton Brown, because when you were talking about the LTC private market in the United States, I was not sure I understood correctly the reasons behind those realities where the profits of the private insurance turned out to be actually very low, and that the insurers are exiting the market. So what were the reasons behind it? Was it what Lenno mentioned, that there is no public system in place to support the private service offer? Or what is the reason that the insurers are actually exiting this market in the United States?
Can I go ahead and reply? Yeah, it's several factors that kind of came together to make this product very expensive for them. One thing that's changed, that's affected all insurance companies, has been the decline in interest rates that we've seen, the secular decline in interest rates that we've seen over the past 20 years. And so basically what they were doing, they were provisioning for having to make future payouts, anticipating that their internal return on savings would be much higher as compared to how it turned out to be. So they found themselves in a situation of, actually they've gone back to regulators. I referred to aggregate risk. Well, the aggregate risk was really, the big one was interest rate risk. Is interest rates have moved down in a way that they weren't expecting. The second thing that's happened is that retention rates, people drop insurance. And they discovered that people didn't drop this type of insurance, that they hung on to it much longer as compared to other insurance lines. So, and some of them, we're offering services and just expensive services. That's changed. They're no longer offering kind of full coverage type products. They're offering partial coverage now. That was kind of the third thing, is the cost of nursing home expenditures has risen more rapidly than the general cost of living in the United States. So those are probably the three most important factors.
Thank you.
I want to mention, actually, there's one thing I forgot to mention. This secondary payer business is really important. In the United States, you have Medicare, which is health insurance for retirees. And Medicare is a primary payer, so you can top that off. And that market seems to work reasonably well. Medicaid is the secondary payer, which means Medicaid pays after your private insurance is paid. And that reforming that in the direction of Medicare might be a positive development in terms of making it more attractive for people to purchase private long-term care insurance.
Thanks. Jürgen, would you like to comment or ask a question?
Yes, of course. I just want to say thank you all very much. Most has been said, I think. Most important has been said. Thank you.
Thank you so much. We have one question from the Q&A session. Kuvarlan is asking, what are the most promising options or changes we could do in order to increase the efficiency of the current LTC systems, especially looking at the demographic outlook and changing in the composition of the diseases and reasons why people need LTC. Anyone dare to answer, react to this?
I'll say one thing about the efficiency of systems. I think there's a lot that can be done, certainly in the US system, to increase the efficiency, because we have a lot of sort of stickiness in our system, where there's sort of one way of paying for nursing home care and becoming eligible for nursing home care. And then there's sort of a different system in every state to qualify for home and community-based services. And what you have is sort of the payment system sometimes driving where people get care. And so sort of smoothing these systems out in some way so that you sort of rationally incentivize the kind of care that you want. So if people want to be at home, perhaps subsidize that in some way, support informal caregivers, and then as people's care needs increase, perhaps consider funding the nursing home care part. We don't have a system like that has that kind of efficiency and sort of smoothness across different settings and payers right now. So certainly a system like Germany's, I often point to Germany's as a system that has sort of a lot of rationality to it, in that they support home caregivers. They even pay family members in order to provide care at home. They train them, they monitor them, and then they subsidize to a lesser extent more expensive types of care. And so they're also facing financial struggles, but I feel like at least it's a more efficient continuum of sort of allocating subsidies where they're needed.
Thank you so much. This was one of the questions I wanted to ask, but our time is running up. Was the ratio between home and community-based services and the nursing homes? Is that a cost or it's efficiency trade-off there? But I'm afraid the time is running up. So if there's something you would like to say to conclude, then I'll give you a minute. And otherwise, I would really like to thank you. I'm really grateful for taking the time, joining us today. I really enjoyed the discussion. I think that we brought out many of these challenges that need to be tackled for the future. And it's not that one system will solve it all, or wondering that does it all. We really need different sources of financing, and we need to be clear on what these different sources can do and how far we can go with them, and what services can be provided and whatnot. So thank you so much for joining us today, and I hope you have a nice day. In the US, in Chicago, Atlanta, you have a day ahead. In Estonia, Finland, we're concluding the day now. So thank you so much, and bye-bye.